I've got a pleasure to invite Professor P.K. Goel. He's going to talk about selection and appropriate use of specialty guide wires. So now the real business end starts in the CTO PCI. Once you have decided how to do, what to do, this, whether these cases need to be done, and you've assessed your angiogram, then you need to know your toolkit.
Okay, thank you. So what I am going to talk on is the understanding the CTO wires, basically, the specialty CTO wires. Majority of the discussion will be on the Asahi wires because that's what we use largely. Now, this is the first slide which tells us about the physics of CTO wire tackling. I think this is very important. You know, there are three forces which are working when you are doing a CTO. One is the wire tip force, which depends on the stiffness of the wire. Second is the resistance in the loose tissue of the CTO, which you will truly traverse in an antegrade CTO. And third is the resistance in the plug. So what you really want is that the wire tip 1 should be more than 2 but less than 3, so that it goes through the loose tissue and doesn't get through the plug outside. But that does not happen all the time. And in this physics, if you understand, if your guiding catheter is going back while working on the CTO, the guiding catheter backup force is also acting in tandem to the wire tip load or the wire tip force. So if it is going back, that means either your wire is not as strong, you have to improve the wire, or you have to improve the guiding catheter support. So with this, you will be able to tackle or go forward. This is the basic principle. I think microchannels, everyone knows there are channels which you cross. And in the antegrade wire techniques, you have the antegrade wire escalation where you try to go lumen to lumen. Antegrade directional penetration, and then you penetrate with a stiffer wire and then step down. Sometimes you get into an inadvertent subintimal entry, and then you redirect the wire back in which you can do it with the Gaia type of wires, and usually the 3D wiring concept helps. I'll show you what the 3D wiring concept is, which we have just published. Parallel wire is the other thing that can be done. So, and then you have elective antegrade dissection re-entry, which you can do with the help of a crossbars, or you can do with the help of a knuckle wire. And lastly is the salvage ADR, or the salvage dissection re-entry, which you will use when you inadvertently get subintimal in the distal vessel, and then you use the stingray balloon and try to re-enter because you have already reached the distal vessel, as long as you are within the vessel architecture. That's important. Now, wire choice decision-making factors are, one is the duration of occlusion. We understand that. If it is a post-MI setting, I think a pilot type of wire is good for a post-MI setting till about 3 months. Microchannels, if you see, then something like a XT wire, XT, XTR, these may be good wires to cross. Proximal cap is tapered versus blunt. If it is tapered, then most of the hydrophilic wires you could try. But if it is blunt, then you need a penetration type of wire, which could be any grade depending on how tough it is. If there is a bend or tortuosity, then again you have to see how much in tortuosity you cannot use a conquest type of wire. You should probably, because there it usually goes straight. So that is important. Calcification, you have to understand if you're using a Gaia type of wire, there's a calcification. I'll just talk to you about it. And then if there's a branch point at the distal cap, then ADR technique may not be the best technique. This is the same thing that I just talked, less than 3 months, more than 3 months. Post-MI pilot is a good option. And tapered tip, the CTO segment is non-bendy than anything, but if it is bendy, then no conquest. Calcification, Gaia can get stuck, so that's that. Now, sometimes you feel, let us use a softer wire, but a softer wire may not always be safer. Understand this. So this is the warning against medium soft wires. They are soft enough not to cross the obstructions in the CTO, like the calciums and stuff, but they are strong enough to get subintimal. But a stiffer wire will cross that calcium provided you will direct it properly. So sometimes stiffer may be better, and this is exactly what it shows. softer wire goes subintimal, but the stiffer wire goes in straight. My choice of wires for antegrade approach, usually step 1 is a XT type, Fielder XT, second is a Gaia 2, and third is a Gaia 3 or Conquest, depending on what wires are available as of today. In the step-down approach, once a proximal cap penetration is done with a stiffer wire, then you step it down, because usually you have to understand the CTO as a proximal cap, body, and distal cap. So proximal cap is tough, body is easier to travel, and then you get subintimal at the distal cap. So distal cap is again tough. So if you understand it like that and then do a step down, it may be better. Wires for collateral crossing, collateral selection is usually good with Sion, but when you traverse these, then Sion could be used. If it's slightly bendy, then a hydrophilic wire like Sion Black or XDR, and sometimes for sharper bend, SUO3 may be better. But whenever there's a branch point in collateral, then Sion is always the best wire. And wires for retrograde CTO crossing, sometimes CTO, Sion itself may go through. Second level is Ultimate Bro, a 3 gram wire. Gladius is a new wire that has come, which is again 3 gram load, and then it goes retrograde, but you can direct it. Ultimate Bro you cannot direct, so that's the good part of it. Third level is Gaia or Conquest. And then the reverse cart is usually done by Gaia, where you can redirect it into this plane that you have created. Largely, wire handling is done by 2 basic principles today. One is a controlled drill where you rotate the wire, and largely depending on the CTO lesion, the wire goes down. So it moves on its own depending on the resistance physiology between the wire load and the CTO. Second is the active penetration, which you will do with directional penetration, rotation and directional penetration, which is through the Gaia type of wires. The CTO wires you have to understand in terms of tip loads, tapered versus non-tapered. Most of them are tapered. Different wires have different taperings. Coatings, hydrophilic and non-hydrophilic. Several times, the Sion Blue has a hydrophobic tip 1 millimeter, because hydrophilic coatings make the feedback difficult. It just slides through. So you want the feedback from the lesion, that's important. Penetration force versus penetration efficiency. The force is depending on the tip load, like the Gaia wires have lesser tip loads, but they have a better penetration efficiency because they have their structure of a tapered microcone and all that stuff. And then the torque transmission, 1:1. This is very good with the Asahi dual composite core design. So most of the composite core wires have 1:1 torque transmission, so that you can direct it where you want it to go, provided you know where to put it. CTO wire designs usually are core to tip, so you must know that. And that's the picture showing the dual core of the Asahi wires, which is a central wire, and then you have 6 wires wound around it like a rope. So that's the and then so the composite core wires are the XTR, XTA. The plain XT is a single core wire, and then we have the Gaia series of wires. The Conquest and Miracle series of Asahi are core to tip design, but they don't have the dual core, so directing them is a little more difficult. This is a picture showing the softer wire. Well, it moves, you feel good, but it bends and it will not go through the lesion. You have the stiffer wire like the Conquest, it will move forward, but then you can't redirect it. And the Gaia wires, you can do that, I'll just show you. I think just to understand, Fielder XT is one wire which is 0.9 gram tip load, 0.9 inch tapered tip. The tip load is about 0.8 gram, and it's a very good wire for control drill. If the lesion has some soft tissue inside, like I told you, several have loose tissue within the CTO, then it can go through. The XTA and XTR have the composite core design. You can direct them. The tip diameter is 0.10, and the load is XTR 0.6 and the XTA 1 gram. This is the micro cone that it shows, Act 1, which helps in greater penetration of the Gaia wires. So it gets you tip flexibility, greater penetration efficiency, and direction and control. So you can literally guide the wire, provided you know where to go. So now within these wires, now you see it's like Gaia, the Gaia 1 has only a tip load of 1.7 grams, but penetration efficiency is close to Miracle, more than Miracle 6 or 9, 12 somewhere. And the Gaia 2nd, 3.5, and Gaia 3rd, 4.5 grams only, but its penetration efficiency is more than Conquest Pro. This is a picture which explains what happens because of the better penetration efficiency. The wire moves inside the calcium all around, but it cannot penetrate the calcium and gets stuck there. And then when you rotate it more, the stuck wire gets over torsioned, and then the coil, because the coil on the Gaia 1 is a single coil, the outside coil, and it breaks, and because of that you can sometimes stick that wire there, and when you pull it out, it comes out as an unwind coil. So tips to Gaia wire manipulation: never over rotate, always advance a few millimeters, 2 mm, and then withdraw 1 mm to see that you're not stuck in the lesion, and redirect and advance always. The Gaia next is the advancement for it. Well, it's pretty old in the Japanese history, but we don't have it. So I think I will, in the interest of time, skip the Gaia next. This is the 3D wiring concept of re-entering, which we just published. This is actually the concept of Okamura, which was first published in 2016. But it is on an experimental model. But it wasn't very clear. So we basically made it cracking the code. What I have done, and that, the wire, you imagine the wire in 3 dimensions around the true lumen. So the wire could be in any 8 positions, and the wire tip could independently be on another 8 positions of that location. So you have 64 combinations. So we have worked out algorithms for those 64 combinations, and if you have that concept, it can help you re-enter like how much to rotate. So the wire is left and posterior, the tip is right and posterior. So you probably, once you locate that through the algorithm, you rotate it 90 degrees upwards, and you will be hitting towards the main lumen, and biplane sometimes helps in better. This is a new wire from the Abbott family, which has just come. I have not used it. This is called the Infiltrack, which is similar to the Conquest, but it is pre-shaped, better 1:1 torque control. And the pre-shaped thing gets you, and the tip has some, it's like a golf ball, semicircular golf ball. It has some indentations at the tip, which in the micro tip, which helps it to catch the CTO lesion and really penetrate as per direction, as we do with the Gaia. Some equivalents of the other wires: XT equivalent, there's a Boston wire, Fighter, which is as equivalent. Conquest has an equivalence of Hornet in the Boston, and Conquest, as I said, Infiltrack in the Abbott. So it's better to use the wires that you know rather than the ones which you don't. You must gain experience in one set of wires and then go ahead. I think this is just, we'll skip these pictures. Summary of my CTO experience, we'll skip on that. And so to conclude, friends, need to have a good understanding of the CTO lesion, the wire structure and its functional abilities, and wire handling skills to be able to make an appropriate selection and stepwise switching from one to the next. And you must always know when to stop. That is the most important thing. Thank you.
Thank you. Thank you, Professor Goel. This is an excellent talk. Really very useful for the fellows. Because you see, the 85%, the success or the failure is the wire cross. That's the basic. And the other issue is that you should agree that the Gaia wire entry into the market in 2013 or 12, I think, made big difference in all our success rates anti-grade.
Yeah.
And third thing is the tactile sensation. Some operators agree there's importance of tactile feeling, like Sumusuji says there's not importance for the tactile feeling, but I feel the tactile sensation is very important. Feel of the wire is very important. That's points I want to make.
Actually, just talking on that feel of the wire, I think it is very important to get the tactile feedback. And today with Gaia type of wires, it's very important to see and understand that if I have rotated it 45 degrees, has that rotation happened at the wire tip or not? If it has happened, you're probably in the right plane. If it is not happening, that means you are stuck somewhere and you better not do more.
See-
So that is a very important tip to catch on.
Since the Gaia wires have come into picture, the shelf wire has decreased. Now we have most of the wires off the shelf, and most common wire used initially is Gaia wire, with the limitation that is unravel when you is stuck up in the lesion.
Yes.
Unravel. That's the most important point. Second most important point is once you are traveling the lesion, most of the time once we have crossed the proximal part and the body of the lesion, we are very enthusiastic that we have crossed the lesion. Then we push distally. That distal dissection is most common as compared to proximal and mid segment. So be very careful at the distal part of the lesion when you're crossing with the Gaia wire specifically.
Okay, we take one question from the audience, if there's any question from the audience. Otherwise, in the interest of time, we'll move forward. Okay, just a last question. In 3D wiring, do you use rotational angiogram or...
Well, 3D wiring, if I have biplane, I will see on both sides, biplane. If I don't, then I have to see it. It's not a rotational angio, but you see it in the LAO and then you see it in the RAO. So you have to move it to the RAO. And depending on the locations in LAO and RAO, you identify where exactly it is placed in space
Right.
around the artery.
Thank you.
And then the tip where it is placed. And then depending on that, there are 64 combinations, 64. So we have worked out, we have a printed
Yes.
64 combinations.
Let us see
available.
how practical
And,
it is in the day-to-day practice when you do on table.
Yes.
It seems to be very unlikely. Anyhow, it doesn't matter. Now we are going to like to Goel. Thanks for a nice lecture.